It gives me such joy to see everyone here. As Ole said, in 2013, I presented to a small group, maybe 30, 40 people. And many of them were just learning about IMR for the first time. So what you've accomplished in 4 or 5 years is just amazing to us. And Kim and I are both so pleased by what's happening in Norway. I would also like to thank our hosts who have done an extraordinary job of organizing this program and our next 3 days that we're going to be here in Norway. So we have a chance to meet more people who are implementing IMR in different settings. To begin with today, before the break, we'd like to talk about IMR as an empowerment tool and how the different aspects of IMR really lend themselves to you having the tools to work with individuals who experience psychiatric disorders to really give them the power they need and the knowledge and skills they need to manage their own lives. And I'm just going to it seems like it's not really turning. Sorry. But I can speak from without the slides too. I'm not attached to the podium. What we hope to talk about this morning is to talk just a kind of a brief history of IMR, from where it started to where it is now, including some of the places in the United States and in the world that IMR is now being implemented. In the US, I might say, you have many cousins. So throughout the world, there are people who are, I would say, speaking IMR. And so the fact that Norway is in this community, it's like a big family. We'll be talking a little bit more about that. We'll be talking more about what we've learned from that implementation. What are some of the things that we might know more about now than we did when we first started out? And we're also going to be trying to answer some of the questions that the organizers of the program conveyed to us that said that you were interested in hearing about. Things like, what is it like to go from a practitioner-centered model to a client-centered model? What are some ways that people can set really important personal goals with the clients that we're working with? And also, who is IMR good for? Who does IMR apply to? How might we expand the circle of who IMR is provided to? And then we would like to, as well, after the break, we'll be talking about more about how to tailor and adapt IMR for different populations. And one of the things I just hope that we have an opportunity to do is to show a short video of IMR as implemented in St. Louis, Missouri. They had a graduation ceremony for the clients who had participated in IMR, and they were kind enough to videotape their graduation. And we have a very short video of clients themselves speaking about how IMR has been helpful to them. So that's just kind of give you an overview of what we're going to be doing today. And we're going to be starting with Kim Mueser, my colleague, for, I think we figured out 32 years, 34. We started off in Philadelphia working with families of persons who had schizophrenia. And then we've continued to work together because of our belief that whatever we know as professionals, we need to share with clients. Whatever clients know, we want to hear about. So we have that same idea of going back and forth, that it's a circle. It's not a one-way street from practitioners to clients or clients to clients. We're all in this family together. So Kim, would you like to start with us?
Sure. Good dog. It's great to see everybody here. It is wonderful to be here and to see this many people with familiarity with the IMR program, interested in and the development of it here in Norway. Susan has already given a an overview of what we're going to be talking about. And we're going to start off with a very brief history of IMR. We know that many people are familiar with IMR, and so what we want to talk about is a little bit about the history and a little bit about what we call IMR in the world. In other words, the uptake of IMR in different places and the impact it has had in many countries. So if we start off in a nutshell and talk about what IMR is, we like to describe IMR as a step-by-step program that helps people set meaningful goals and then to acquire information and skills in order to develop a greater sense of mastery over their own psychiatric illness in order to pursue and achieve their personal goals based on what recovery means to them. And the history of the development of illness management and recovery goes back to a project aimed at implementing evidence-based practices back in the early 2000s. And illness management and recovery was identified as one of 5 different sets of evidence-based practices that we were interested in studying the implementation of in routine community mental health treatment center settings. And the other practices identified there were assertive community treatment, supported employment, family psychoeducation, and integrated treatment for co-occurring disorders. But at the time, the illness management and recovery program didn't exist as a cohesive program. There were many studies, about 40 randomized controlled trials that had been done of different illness management interventions aimed at decreasing symptom severity, reducing relapses, and trying to improve the course of psychiatric illness. But these different studies, these different programs had never been integrated into a single cohesive program. So what we did was, based on a survey of the research literature, we identified 5 different empirically supported intervention strategies. Psychoeducation, to teach people information. Now, it's interesting, we called psychoeducation the teaching of information about a psychiatric illness and the principles of its treatment. We said that that was important in its own right, independent of its effect on the course of the illness, because we believe that mental health service users need to have information about their psychiatric illness in order to participate in shared decision-making with other people. And so we said, independent of what knowledge of mental illness does for the course of the illness, it is an evidence-based practice. It's a part of illness self-management in order for people to participate in making decisions about their illness. All of the other parts, the evidence-based practices that we incorporated into IMR had been shown to improve aspects of the course of the psychiatric illness. The tailoring of medication to fit it into people's routines for people who take medication. Teaching coping strategies for the management of persistent symptoms. Teaching relapse prevention to prevent symptoms from relapsing. And skills training to improve the quality of social relationships and social supports, since we know that social support helps buffer the negative effects of stress on precipitating relapses. So the first edition of the IMR program was published by SAMHSA in 2003. It was then revised. Revised edition was published in 2010. And there was a 3rd edition that was published in 2011. So if you had to say, well, how does IMR work? In one slide, I would say the following. You begin by engaging people and trying to inspire them with the concept, with the idea of recovery. Recovery meaning that people can recover the sense of themselves, a sense of purpose, and their lives. Even if they continue to have certain symptoms, it doesn't matter. Recovery really has to do with a sense of meaning and belonging and purpose. And that based on what recovery means to each person, individuals set personal goals, they work towards those goals, and then the rudiments of illness self-management are taught as a way of helping people make progress towards their goals. And so it, in effect, builds in motivational enhancement from the beginning, in that you can explore with people how learning different aspects of illness self-management can help them make progress towards their personal goals. And so the idea is to remove illness-related barriers to helping people move forward in their lives in whatever ways are most meaningful to them. So practitioners meet with people, they set personal goals. Then, after having set personal goals, they teach illness self-management. And at the same time, while teaching illness self-management, they're helping people break down goals into smaller steps, take practical steps toward achieving goals, problem solve around obstacles to achieving goals, explore how improved illness self-management can help them achieve goals, bring in people from the support system to help people make progress towards goals and learn illness self-management, help people practice the skills outside of the sessions as well, and to integrate the work of teaching illness self-management and making progress towards goals with their overall treatment and rehabilitation plan. I mean, clearly, if you're going to teach people how to manage their own illness more effectively, you need to have regular contact with the treatment providers, the doctors prescribing medication. If people are providing CBT for psychosis or some kind of psychotherapy, coordination with them, with rehabilitation, whether it's supported employment. You want the illness management and recovery to be part of the glue that holds the person's entire treatment together and helps it make sense, most of all, to the client, to the person. We sometimes like to use this analogy. This was created by Patricia Deegan, herself having had diagnosis of schizophrenia, and a very eloquent speaker about the experience, and also a clinical psychologist. That recovery is about putting yourself back together, putting yourself, in this case, the client, Marie, at the center of herself, and to have the different aspects of oneself, including a psychiatric illness, but other aspects too: culture, family, sexuality, work, politics, to have all those as a part of oneself, but you being at the center, as opposed to, we have another figure where the illness is at the center and much, much larger, and where Marie, the person, is just a small part, but the illness dominates the picture. The idea of illness management and recovery is to put the person back as the center of his or herself. So, contents of IMR cover a broad range of different topics. We don't need to go through them all here, because I think the people will be familiar with them. And these slides, I assume, will eventually be posted so that people can get access to them and corrections made. The overall conceptual framework of the IMR program, from an illness management perspective, the recovery perspective you already understand, the motivational enhancement. From an illness management perspective, it's loosely based on the stress vulnerability model. The idea of the stress vulnerability model is that the course of psychiatric illnesses is caused by a combination of certain biological factors, but also social factors and stress. And that based on this understanding, there are a wide range of different strategies that people can influence the course of their psychiatric illness. People can learn more effective coping strategies for dealing with stress and coping with symptoms. People can enhance social support that can help both in terms of achieving goals, but also in terms of coping with symptoms and reducing stress. People can choose to take medication for weighing the pros and cons, which may reduce some of this biological vulnerability. And people can reduce their use of substances, which can also trigger symptom relapses and more severe symptoms for people, partly because of their biological sensitivity. And last, part of the stress vulnerability model, is that being involved in structured and meaningful roles, it could be working as a volunteer, working as a part-time job, returning to school, a variety of different things. But there's many good reasons to believe that these structured roles actually provide meaning but reduce stress as well. Because we know when people don't have anything to do with their time, when people are in unstructured activity much of their time, psychotic symptoms tend to be worse, depression tends to be worse, and people tend to be more prone to using substances. So helping people get into structured, meaningful roles is part of what we help people do in illness management and recovery. And its theoretical basis really is in the stress vulnerability model. So IMR typically takes 40 or 50 sessions to do, although it's possible to do selected sessions and things like that. We'll be talking about different tailoring later on. The format is flexible. You could do an individual format, you could do a group format, you could do combination between the two. IMR can be provided in a wide range of different settings. It can really be provided in any particular setting that services are provided, including in the community, but in inpatient settings, outpatient settings, residential settings. Typically, session length is 45 to 60 minutes. In certain groups, you may have longer periods, like 75 minutes. If you're working with people who have a lot of cognitive challenges, maybe intellectual limitations, you may choose to have shorter sessions. And so, to do a little bit of a transition, to talk about IMR in the world, and this is kind of our way of talking about the uptake that has happened in the 15 years since the IMR program was developed. This here is the announcement of a cookbook that was formed by an IMR group at a transitional living residence for people with substance use disorders. Now, it's interesting, in this particular residence, not everybody is diagnosed as having a co-occurring disorder, but everybody participates in the IMR program and reportedly gets tremendous benefit out of it and finds it a very normalizing and helpful experience. And one of the things that they did as a part of their group is they announced that, if you may be able to see, that it's the Residence Illness Management and Recovery Group's ultimate goal more than a cookbook. And so it is actually a cookbook you could buy with recipes that is essentially from the different members of this group. And this is at Elwyn. It's a residence outside of Philadelphia. So these are translations of IMR. And as Susan pointed out, these are translations in addition to Norwegian, because of course, we hardly need to tell you folks that there's a translation of IMR into Norwegian. It's not like we would have forgotten to put Norway on this list of languages. And there's been quite a bit of international research on IMR, and more is coming out all the time. The initial effectiveness of illness management and recovery. For several years after IMR came out, and people would talk about IMR as an evidence-based practice. And I'm a clinical psychologist, but I'm also a researcher. And I'm very serious about the evidence. And so at first, when people would refer to it as an evidence-based practice, I would always say, well, it's actually a practice based on the evidence, but we still need to study it. But then I became a little bit more comfortable because over the next 5 years, 3 different randomized controlled trials were published of the IMR program, each in a different country and in a different language, and each of them demonstrating beneficial effects. So these were studies in Israel, Sweden, and the US, all carefully done randomized controlled trials. Without going into details, all showing beneficial effects of people who participated in the IMR program as compared to services as usual. And then there are more recent randomized controlled trials, and there are more coming out every day. There's going to be one that's going to be coming out from Denmark, probably within the next several months. And just to warn everybody, not every trial of illness management and recovery is successful. I think it has to do partly with the ability of the researchers and the ability of the clinical settings to embrace and understand IMR in order to figure out how to make it work in their own setting. So the first of the studies here by Michelle Salyers, who is a good colleague of ours, didn't produce very positive findings, but only about 25% of the people in the study who were assigned to the illness management and recovery group came with high regularity. And the study that's coming out from Denmark also didn't find positive results. They had a little bit higher attendance rates, but there were still problems, I think, with the implementation of it. So IMR is a tool, and the way you implement it and the way you use that tool varies from setting to setting and from the clinicians providing it and from the consumers who are using it. One other study, the one from Tan from Singapore, did produce very, very positive findings. But I'm just letting you know it doesn't always work every time because it has to do with how well you embrace and understand the program in your own setting. I want to just do a little bit about saying, well, what have we learned from these 15 years of providing illness management and recovery as a program to places throughout the world? The first thing is that we've learned that is if you create accessible content, information about mental illness and its management, that people will access it and they'll use it and they will learn it. 3 or 4 months ago, I was in Bangkok, Thailand, for a recovery-oriented conference. And when I was there, I met a young gentleman and his mother. The man was from Malaysia, and he said 2 years before, he had learned about recovery from the illness management and recovery program, that he had benefited from it, and that after having gone through the program, he became a peer support provider. And he provides peer support, he does some teaching of illness management and recovery, and he goes to different conferences, and he was there with his mother. And it was just a very interesting and heartwarming experience for me about how the notion that recovery was possible meant so much to him. It didn't mean that he didn't have symptoms and things, but it meant that he was able to move forward in his life. A second important lesson is that permitting local control. As you know, yes, there's an IMR manual and there's guidelines, but nobody is, or at least Susan and I, are not telling people exactly what they're allowed to do and what they're not allowed to do. It's not controlled in that sort of way from above. Local adaptations are permitted and are sometimes absolutely necessary. And what we've found is that this has spurred adoption. This has really helped people to adopt it. It can also lead to challenges in its implementation. It means that not every adaptation works, and that you do have the freedom to adapt IMR. But ultimately, the test of whether the adaptation is allowed or useful is a test of whether it works. Is it helping people move towards recovery? Is it helping them take over their lives? If it is, go for it. If it's not, that's fine. Do more adaptation, go back, keep experimenting, and figure out what works for you. Another thing that we've learned is that embedding the recovery vision and goal setting into the systematic teaching of illness management has become a very appealing way of understanding a general approach to teaching people illness management. Interestingly, we often see reference to, quote, illness management and recovery when they're not even talking about the IMR program. In other words, the term illness management and recovery in some places has become broadly accepted as an approach to teaching people about their psychiatric illness in order to help them take greater control over their lives, even when they're not referring to specifically to the IMR curriculum and program. It's become something, a framework that I think has gotten a broader a set of acceptance. And so the last thing is that we understood early on from working with service users and or mental health consumers, we understood that the really important thing was to start off with a hopeful way of helping people think about their lives and the changes that they wanted to make. And for that reason, recovery is how the illness management and recovery program begins. You begin with that sense of hopefulness and that dialogue with consumers about how people would like their lives to be different. What it took us a little bit longer to understand is that in order for consumers, for service users to feel that sense of hope, that clinicians themselves, the people working with them, also have to be hopeful. And what we have found is that the language of recovery and that the structured approach or semi-structured approach to helping people set goals based on recovery and learn illness self-management has provided a vehicle for instilling hope among clinicians and family members as well when they learn about IMR. And that has been as important to the overall program, the sense of hopefulness as opposed to futility that mental health clinicians often feel in working with people. And so we have found that the language and the tools of IMR have become a powerful tool for enlightening clinicians about the possibilities of recovery. So.
It was like a huddle for the Super Bowl. You have to talk with your teammates. We were just conscious of the time. And we know your time is extremely valuable, so we want to use it as best we can. And one thing we would hope to do is to have time for questions, because you're sitting there with a vast amount of knowledge about what it's like to do IMR with the individuals you work with. And you may have some questions or comments, and we'd love to leave time for that. I would like to just talk a little bit about the client-centered approach, kind of moving from a practitioner-centered approach to one where we look to the clients to be the center of the directions that we go in. And we think that the way that we really make that shift between practitioner-centered and client-centered is through the process of setting personally meaningful goals. As one of the clients said, why would we learn illness management? For what purpose? And he said, if there's not something that you're striving for, it doesn't seem worthwhile to spend all that time on learning illness management. There needs to be kind of a goal that people are heading towards. And we think that IMR, as you well know, is not just about going over handouts. It's not just about, we're not looking for people to pass a quiz. It's about how do they incorporate the things that are useful to them, and how does it help them get something more in their life that they want to have. We think that what the person's goals are has to do with how you then structure the rest of IMR. What are the modules that make the most sense to that person? How do you make those, within those modules, how do they relate to the person's goals? One of the things that we say is that it's very important that the person defines what recovery means. Because for some people it means having a job. For some people, it means being back in touch with their family. For some people, recovery means being able to take care of their daily needs. For some, it means getting their college degree and getting a life that's rich and meaningful. So once that you help people find out what it is that's important to them, you want to help them to come up with a recovery goal that they can really embrace, that they own. It's their goal, not ours. And it's broken down into a series of manageable steps. And we wanted to address the question of what is the role of clinicians in setting and following up on recovery goals. I think one of the questions that came from this group was, why do clinicians, are they supposed to sit on their hands and just be silent when people are developing goals and make sure that every single thing that goes down on a goal comes from the client? Well, what we've learned is it's an interaction. Is that very often the clinicians don't need to sit on their hands. They don't want to dominate. They don't want to dictate, but they want to help. And we found that oftentimes clients need some help in figuring out a personal goal. They benefit from having questions asked. What was important to you when you were a teenager? What kinds of things did you want to accomplish when you, in quote, grew up? What are the things you used to enjoy that you might be able to enjoy again? What are some things that, what I think of is, what is a goal or what is a vision of recovery that lights up the person's eyes? Not just a goal that sounds good, but one that really kind of makes the person feel alive. And to do that, it's helpful for exploring with the clients what they may have said in the past about their goals, what you might have observed about their talents and abilities, and just asking, I've noticed that you really are so organized. Have you ever wanted to do something that had to do with helping other people get organized or become involved with computers? So it's having that questions in the back and forth. That really, really helps. And sometimes it's helpful for the clinician to be like the scribe, to write things down as the client's talking. Now, some people will say the client's goals need to be in their own handwriting. And if they can write and enjoy writing, that's great. But we don't want that to be an impediment. So oftentimes I'll be taking notes for them. And then I'll say, have I got this right? You said your goal is to become a school teacher. That's what I wrote down. Have I got that right? Is that correct? So you're helping them to put some shape into their own aspirations. And then clinicians are often, once the person's found their goal, they're often very helpful in breaking them down into manageable steps. And that's often something that we all have trouble with. How do we go from something big to something that is, what can I do today? And most of you are familiar with the Satisfaction with Areas of My Life worksheet within illness management recovery, is systematically asking folks, what are you happy with in your family relationships? What are you not so happy with? What would you like your family relationships to be? Just kind of systematically asking, instead of having it be just an open question. What kinds of things do you want to accomplish in your life? Is kind of going through the different categories. You learn that people have more goals than you might have thought. And then again, you're familiar with is the goal tracking sheet, going from satisfaction with areas of your life to setting a goal with one of those areas you're not so satisfied with, and breaking that down into a series of manageable steps. This is the IMR goal tracking sheet in English. And here is just what we call the rule of sixes, is we think of a long-term goal as something that would take 6 months to a year. And we want to break those down into 2 or 3 short-term goals. And by short-term goals, we mean things that might be accomplished in about 6 months. And then finally, you want to break those short-term goals down into steps. And those would be things that you could accomplish within 6 days. And I'm noticing people are taking pictures of this. I appreciate that, because I think the more we understand about sort of the nuts and bolts and how to help guide folks, the better that we come up with. It's like a combination of the head and the heart. I think of illness management recovery. It's like, what are some good tools we can use, and it's at the same time keeping in mind the real heart of that goal, but really breaking it down into be achievable, because it's not so rewarding to have a wonderful goal but never feel like you're getting any place with it. Okay. We also feel like it's important to take your time with goals, to not discourage ambitious goals. We've had folks who want to do things that are kind of far out there in the future. They might be to become a doctor. And they may have the ability to become a doctor, but the idea is that to break it down into really manageable steps is, we don't want to reject that dream of life. Okay. This is some example of long-term goals set in IMR. Everything from getting a job to playing games with one's children, to sign up for an art class, or go back to church or synagogue when that used to be important to them. I think one of our oldest IMR clients was 82, and he wanted to go back to church. And he was very determined. That really made his eyes light up, the idea of going back to church. And so he set a series of short-term goals, and by gosh, he made it. I think that it's really important to find what is that thing that people really want to be doing.